thank you for inviting me to present on my visit to Boston Children's Hospital as part of the Education Practice Fellowship Award from 2013. I chose to work with the complex care team in Boston Children's Hospital to inform, I suppose, my work on children and their parents transitioning to home, and to learn about what is best practice from a very established community that are working in that area. It stems very much from, like I said, my work with parents and children transitioning to home, but also from my background. I'm a lecturer in children's nursing and work on the programme for the graduate diploma on critical care nursing, and I'm specifically looking at this area. So I suppose in relation to children with medical complexity, the importance of looking at the topic really determined, again, the focus for this trip. In the last number of years, there are a steady increase in the number of children with complex care needs surviving beyond infancy into childhood and into adulthood. And when you look at the figures internationally, the survivability is greater, but internationally we are struggling with how the health system and health service supports the needs of these children. From an Irish perspective, it's very much a new area, and from my own perspective, I've been involved with the HSE advisory group looking at models of care for children transitioning to home with complex care needs. From a US perspective, they have services developed probably for the last 30 or 40 years, so it's important to see what's happening and to understand what they're doing that we can learn from. When you look at, and this is just an example of some of the research that's been done in this area in the States, where they look at trends of readmissions for children with complex care needs and also length of stay of hospitalisation. And when you look at that population of children, although in comparison to children in general and ill health in children, they are a small percentage of the population, but their stay in hospital and their need for communication and for healthcare service is much, much, much greater. And I know from a cost perspective, the US have looked at the financial implication of it, and they would suggest that and what they found is that 50% of all of the paediatric healthcare costs in the US are actually consumed by this healthcare group. So for a variety of reasons, we need to get our ducks in a row in what is best practice to look after this group. In relation to, I suppose, where I see transition and my understanding of what is transition, it's very much informed by the work of William Bridges and his model of transition from 2004. And so Bridges would describe three main times in the point of transitioning to a new understanding or to a new situation. So he would talk about endings, losing, letting go. He speaks about the neutral zone and then the new beginning zone. And when you put that in the context of the children and families with complex care needs that we see transitioning to home, from acute services, from respite services to home, across the remit, I suppose what we're saying is that, and where we understand the context of those children is very much between the endings, the losing, the letting go stage and into the neutral zone. So just to explain what they are for a moment. The endings and losing and letting go in the context of children with complex care, this very much speaks to when parents are faced with the reality that what their expectations were of a healthy child are not what they are going to be. So, for example, it could be a newborn who's diagnosed with a complex care issue or with multiple healthcare needs, or it could have been a very well 2-year-old who's diagnosed with a meningitis and has subsequent sequelae that lead them to having ongoing complex care needs. So, for whatever reason the change occurs, this is the period of time where they are faced with a reality and being faced with a change in their perceived reality of what the future of their child was going to be and the future health of their child was going to be. Moving into the neutral zone, which is very much the surreal zone, where they are in a state of almost suspension and disbelief and beginning to try to get their heads around what is now needed to cope with the situation, and then eventually moving to the new beginning zone, where they have an understanding of what will be required and where they have a map to follow for what they will need into dealing with the new beginning that they have to face with. Amongst all of that, there are a number of factors that will influence how they progress. The impact and the severity of the illness the time scale between diagnosis or in the case of an older child, the time they've previously had with a well child before being faced with the new reality. Their readiness, that can be their clinical readiness to care for their child, or it can be their psychological readiness to cope with the new piece. And when they all align together, that is when Bridges would suggest that they move to this new beginning. In a more simpler format, and I suppose one that I like, and from teaching purposes sometimes very handy, that when we look at the neutral zone, and this is the area that we most commonly meet parents in and are dealing with them in, the end of the end zone and into the neutral zone, that they're faced, it's really at a time of discomfort and loss and uncertainty, eventually moving towards opportunity, which as healthcare professionals we have the responsibility to guide them towards. So the aim of my visit was to see what constitutes best practice for the discharge management of these children in the US with the established complex care team at Boston Children's Hospital, and specifically with Dr. Jay Berry, who very kindly supported this trip. The objectives of my visit were to learn about best practice, to learn about innovations and effective strategies in that, the current state of work on benchmarks, and then to collaborate with the paediatric discharge team in their ongoing work on a parent-facing guide for the discharge home of children. So, the people I worked with in complex care in Boston Children's Hospital in April for 2 weeks. They are outpatient coordinators, inpatient coordinators, the director of nursing, the medical director of the complex care team, the advanced nurse practitioner equivalents, and the clinical case managers and psychologists who work with this team. It's a very well established team, so it was initially developed as an outpatient service and then subsequently as an inpatient service between the 80s and 90s. What's important about it is that in comparison to our system here, when a child with complex care needs comes into hospital or comes from home for whatever service, they are generally under a particular team, so it could be neurology, orthopedics, but this development of a specific complex care service as a one-stop shop to look at the variety of needs that the children has certainly seems to serve very well. They deliver care very widely, so not just within Boston, but the wider Massachusetts area and also across the US and internationally. Then this, I suppose the second piece that informed my overall outcome from my visit was a 2-day trip that I took with the complex care team to the National Network Conference in Dallas. This was a very enthusiastic bunch of hospital leaders from across the United States, and a representation from across each state, and they gathered together with the goal of with the aim of becoming the most knowledgeable and capable paediatric collaborative for children with medical complexity. They focused on the implementation of coordinated care networks across the United States, and it was an extremely valuable experience for me because when you look at the collective across the United States and the various problems that they face, I suppose it reassures us that we're all on a relatively similar journey. What I wanted to do was pick out 2 specific things from my visit to talk to you about that I feel would be, I suppose, appropriate in relation to where we are with the Irish Health Service. 2 of the challenges that we have from an Irish perspective are that we have no national standards for the care of children with complex care needs. The second thing that we have a challenge with is that the coordination of care of the child's care needs when they move from hospital or from respite service to home is very much based on the parents. The parents are the primary caregivers and they're the main coordinators of care. So I wanted to, I suppose the 2 things that I looked at were what the benchmarks are and how they manage the care coordination piece. Just for a moment, I suppose, to go back, the 4 key areas in total that were of relevance throughout my journey were looking at home care models, innovations in risk-managed network design, the quality and safety standards, which I'll come back to now in a moment, and the complex care population costs and financing. With regard to medical home models, that's very much about how primary care teams are established and set up and monitored and quality assured. Item 2 and item 4 there, very much from a US perspective, speak to the use of cost, the financing of home care packages, how different insurance companies relate to them, and it's a huge topic from a US perspective. So the one that I wanted to really focus on is item 3 there. The standards for systems of care for children with youth with special healthcare needs was only published in March this year, so it was a great time to go over there in April and to and to listen to the rollout, or the beginnings of the rollout of this. This was a product of a national consensus framework for children with special healthcare needs that was funded by the Lucille Packard Foundation, and it's available on their website. And what it is, and it's something that I suppose we aspire to, but it's great to see what they're doing. What they do is they have developed 7 overall system outcomes for children with complex care needs, and then within that 10 domains that they will assess where the child's care and how well it is being received. They will benchmark them against that. So the 10 domains that are of relevance, and I'll give you examples of some in a moment. So they have standards for the screening and assessment and referral of children with complex care needs. They look at the eligibility and enrolment for children into complex care services. The access to care, the medical home, and that speaks about care coordination, prevention and speciality, and then down through them. And I suppose the one that is of particular relevance to this population is the community-based services and supports. So there are standards for what is respite care for children, what is palliative and hospice care for children, and what are the home-based services. There's a very strong focus on family and professional relationships as well, and how and the standards for engaging with parents in the decision-making process. Extremely important from our perspective that we take note of that, because we are asking, and parents become the primary caregivers, but we have to let them and to put support structures in place to enable them. So particularly, that was one that was particularly close to my heart. Then the standards for transition to adulthood, quality insurance improvement, health information technology, and insurance and financing. So just to give you an example of where they're at and what they're doing. In relation to respite care, just very briefly, they have a set of system standards where they look at how families are informed about the availability for access, how healthcare providers plan and screen their parents and children who should access respite services. And they have a particular one in there where they suggest that a standard for care is that there's a system in place for ensuring timely referrals for families of children with complex needs who have emergency hospice needs at home. They then structure their standards with supported by national principles and frameworks, supported by federal law or federal requirements, and then there's an opportunity on the right-hand side for within each state to look at availability of relevant quality measures and how they would measure them. So I think it's an extremely valuable tool that we could possibly use as a framework for here. And together with colleagues in UCD, I'm working with Jay Berry and the complex care team in Boston Children's to look at moving this from the US to a European context. They also then, just the other example that's there is the palliative and hospice home care piece. And with regard to that, it's very important, the whole piece again is that parents and their family have an active role in the decision-making process. The parents and families' role in the decision-making process is threaded throughout, and they have a particular section on family and professional partnerships, talking about culture, talking about ethnic diversities, but very much talking about the partnership in decision-making frameworks. So I think that's something that we can look into further into that and look at its value from an Irish and European context. The other piece of work that has been developed and is being developed further over there is a care coordination measurement tool. The reason that I felt that this was particularly important to highlight, again, is because of the care coordination focus of parents when they're moving to home, and the burden of work that they have to organise carers coming into their home, to organise their trips to various services, to liaise and link in the whole time. So effectively, many of the parents that come through our services are the care coordinators. From a UK perspective, a lot of work has been done about the role of the case manager. From a European perspective, limited work. But in the US, I thought this was quite an interesting tool. So what they do is, Dr. Rich Antonelli in Boston Children's Hospital developed this tool. And again, this is freely available on their website, on his website, on the Boston Children's Hospital website. What it does is it is a measurement tool that captures the activities of care coordination, resources that can be used to implement those activities and the resulting outcomes. And it's been very well validated, widely used to capture the work of care coordination. So what nursing do, what social workers do, what case managers do, and the entire multidisciplinary team, what actually is involved in the care coordination and what the outcomes are. So just to give you an example of what that is, and again this is freely available on their website. what they do is they capture the patient level, the care coordination needs, the time spent, what that time was spent doing, what the outcome of it was, if the activity fulfilled the needs. So what happened as a result of the engagement with the child, whether it was form processing, whether it was a clinical visit. And it's a very good assessment tool in the early stages after a child transitions to home to get a good grasp of what their care needs are. It could either be used as a supportive mechanism to help parents I suppose refine and help them identify what their needs are, but also very much from an assessment, maybe even 6 weeks, 8 weeks after a child moves home, to again reassess what their care coordination needs are and who is best served in relation to the entire multidisciplinary team to be going in and out to the child on a regular basis to work with them. It takes consideration of every type of encounter that is possible, including dietetics, social work, medical management, education and the mental health of the child. So that was an example of that. I think from an outcome perspective, it's something that could be very, very useful in the environment that we work in. The last two pieces that I want to speak about are my trip to the Franciscan Hospital for Children and then the work that we did with the parent advocacy groups. The Franciscan Hospital for Children is a transitional care unit and it's called the JEGS Unit for Pulmonary Rehabilitation. It's a standalone unit in that it's set away from Boston Children's Hospital, so it's a long tram ride away, but it's a separate unit. And what they do is they have a role very similar to the role that a transitional care unit has in our acute hospital services here. So the children that are not ready to quite move into home, but with complex care needs, but are too far advanced in their care for the acute services, move in here. Their parents come and spend time with them, and this is a whole period of getting them ready for home. They focus on their clinical readiness for home, on the psychological well-being of the child and the family and the parents moving into home, and they with a main focus on medical, nursing and therapeutic services. The significant focus in all of this is supporting the parents to be empowered, to feel confident and competent to care for their child when they move to home. So in many respects, it very much affirms what we do from an Irish perspective in relation to transitional care. And I think what it does is it solidifies the need for this type of unit, but even maybe more of this type of unit. The parents that I spoke to in the unit were really supportive of and highly appreciative of this type of environment for their children and the support from them, from the staff and other parents in the preparation to moving from home. And the final part of my journey, I was really lucky to be able to spend time with the Boston Children's Hospital Family Advisory Committee and to be part of a teleconference with Family Voices, representatives of Family Voices, which are a national advocacy group for parents and children in the United States. And what struck me most from my times talking with them was their enthusiasm for parental engagement, and many of the issues that they raised mirrored many of the issues that parents raise from an Irish and European context. But there were two things that struck me in particular, and that areas that we might consider for further development. One was how healthcare professionals begin the conversation. So how the conversation starts that a child will have ongoing complex care needs, what that might mean, and what the parents there were suggesting was that the need for very real conversations about what the pitfalls will be, what the expectations of parents will be. And they really wanted, I suppose the message that they wanted and that we took as part of a wider research team over there was that how and when that conversation starts is something that we really need to focus on a lot more. That over the cot or over the bed isn't appropriate, and that the people that are involved at that initial conversation, that they are very much briefed on the supportive needs for parents at that time, and that it's done very early. The other piece that came up very, very much that was I found really interesting was the first time versus frequent flyer information needs, because I suppose we're sometimes very much focused on parents' needs at the initial start, and sometimes there's a one size fits all in relation to information needs at the time of discharge. But there one potential way forward, and I know parents with children with complex care needs are often very tied with their time, but what the parents here were suggesting was that they'd love to be more involved. The frequent flyers would like to be more involved with parents, first-time parents, to support them more. But they felt that the frequent flyers and the people that are in and out with their children, or have a lot of contact with hospital or respite services, that their information needs, they would like their information needs to be very specific to them, and that very more specific to their child, rather than just a regular discharge pack. So just thought there were two things that we could bring back and inform how we're progressing our work. Part of this was linked in with the development of the parent and patient facing guide and a framework, a checklist for discharge planning that Boston Children's Hospital are developing, funded by the Lucille Packard Foundation, which I'm involved in. And that framework for discharge will be published later, early next year. So that will be another outcome from this visit that will be good to disseminate further. So overall, the outputs from my visit, in summary, it's been extremely helpful in relation to informing my curricular development at undergraduate and at graduate level. It's also extremely informative in developing a collaborative research agenda on children with complex care needs, and this has been borne out in the last number of months. I currently have 3 funded projects in this area, and the engagement with the AIHPC and the opportunity to visit Boston Children's Hospital was enormously beneficial in understanding what the needs are from an international perspective and where we need to be going with our research here. It also afforded the opportunity to strengthen links and develop more for collaborative further research in this area. I would very much like to thank Ms. Paddy Blaney, Dr. Michael Connolly, Karen Charnley and Bernadette Peary for their enormous help and support in getting this fellowship off the ground, and their support of me in my time in Boston and on return. I would like to thank Dr. Jay Berry from Boston Children's Hospital and the complex care team, who put an amazing agenda together and took me down to Dallas and looked after me so well in engaging with parent groups and accessing all of the various areas that made it possible. And finally, my colleagues on the school, in the children's team in University College Dublin, and our head of school for supporting me to be able to take this trip. Thank you.